one of the ways of understanding the new medicine service is to think about yourself when you'd have a new technology, like a new camera like this one, which I bought recently. A new smartphone, something like that. In the shop, people may have told you about it, they've explained it to you, you've got it home, you've got a manual, you've been through the manual, you've started to use it, maybe you've looked things up on the web when you've had a problem, but there are still things you don't know what to do about. There's a little lever on the back here, I'm still not sure what it does. So what you want is an expert to come along, sort of put their arm around your shoulder and say, what are your problems? How are you getting on with it? Can I help you get more out of it? And that's what this new medicine service is about. It's about doing that with medicines instead of technology. And you want them to just solve your problems and also perhaps to tell you some things which you haven't known, which would have made your life easier as well. And that's it. That's the new medicine service. One of the things we wanted to do was find out whether there was a problem, how much of a problem there was with medicines. So we did a study where we followed up over 200 patients from a range of 20-odd pharmacies. And these were patients over 75 or with cardiovascular disease or asthma, diabetes, things like this. And we called them at 10 days on the phone and said, how are you getting on with your medicine? Are you managing to take it okay? And do you have any problems or concerns or issues? And then we called them again at 4 weeks to see whether these problems had gone away, if there were any. And what we found was that at 10 days, a third of the patients weren't adherent. And about 13 out of that 230 had already stopped taking the medicine and gone back to their doctor. At 4 weeks, a quarter of them were not adherent, but already another 26 had gone back to their doctor to get things changed by then. So there's a big problem with adherence and satisfaction with the medicines out there. When we analysed why people were not adherent, about half were intentionally not adherent and about half unintentionally not adherent. They wanted to adhere, but there was some barrier, some problem in the way. Of those that were intentionally non-adherent, most of them had stopped completely. Now, we also asked about problems, concerns and issues, and 2/3 of the patients at 10 days and at 4 weeks said they had problems or issues. And half of those were to do with side effects, and most of the rest were general concerns about the medicine and taking it. Now, this is a pretty damning situation to be in, really. Here we are spending 10–12 billion pounds a year, 850 million prescriptions a year, and yet we've got a quarter to a third of people not taking it and 2/3 worried about it. Now, if this was any other technology, and remember that medicines are a technology just as much as your smartphone is, if this was any other technology, it would be out of business. And we really shouldn't tolerate this, and we've got a large role to try and put it right. Why do people have these problems? Why is this occurring then? What's the cause of all this? Well, some years ago we did research where we interviewed patients a day or two before they saw their GP. Then we'd tape record the consultation, then we'd interview the GP and the patient separately a few days later. And all sorts of issues came to light, as you might imagine. It's very hard to fit a consultation to diagnose and prescribe and everything into 10 minutes. Some doctors treated the patient very much in a biomedical way. If you look at me, you can say, here's a man, he's in his late 50s, he's 80-odd kilograms, his renal function is this, and his hepatic function is that, and you can describe me that way biomedically, and I wouldn't feel particularly like a person. Or you could say, here's Nick, he's a dad, he's a husband, here's where he works, here are his friends, and you'd see me as a person. And what happens in consultations is if you treat the patient as a lump of meat, if you treat them as a sack of chemicals which are a bit dysfunctional and you just talk about measurements and speak in that way, the patient feels inhibited about expressing anything personal. And we don't want that to happen. So that was one of the problems in GP consultations. Some GPs spoke in that way. We need to make sure that pharmacists don't either. Sometimes the GPs were very patronising, and we know actually from research that pharmacists are too, so we shouldn't feel too superior about that. Pharmacists tend to think they know what's best for the patient. We've got to move that attitude. If you've got it, you've got to think what does the patient want, and engage with the patient. And of course, there's the fact that in the interview, in the consultation, there's a short period of time, information may be given out and the patient may well forget it. It happens to me when I see my GP. And then there's the issues about medicines themselves. You know, you could leave the GP's practice with your prescription, see a pharmacist, have half an hour's briefing and still be stumped when something happens to you later, because there's a difference between population data, the information we give patients about the population as a whole and drugs, and what happens to you as an individual or me as an individual. So what we need to do is find out what happens with that patient. We know that the NNT, the number needed to treat, the way we measure the effectiveness of drugs, is generally bigger than 2. That means that it's really going to give the best clinical effect in less than half the patients. Do we know what the chances are that the patient's going to be side effect free? No, we don't. If I go and buy a dishwasher or a new car, I can look up in Which or various other magazines to find out what the chances are that it will be trouble-free in the first year. With a medicine, can't see whether I'm going to be, whether 20% of patients have no side effects or 80% of patients have no side effects. There's a whole load of information there which we don't know and can't tell to patients. And of course, we don't know what their side effects are and how those side effects will matter to them. If they're a bit tired and they're retired, it may not be a problem. They may have a bit of a snooze in the day. But if they're driving a lorry, it's a major problem. If they're a company director, it's a problem trying to keep meetings going when you're feeling sluggish because of the medicine. So whatever happens, even if we got the prescribing process perfect, there will always be a need to find out what happens to that patient with that drug. And then we can come in and help them with various ways forward so that we can say, yeah, this is reasonable, this isn't, this probably is a side effect, this probably isn't a side effect. This side effect you're having you could deal with in this way, or maybe there could be a different drug which would help you. Maybe you take it at night and then you won't get the tiredness, or the tiredness won't be a problem, and so on. So that's the idea. There are problems within the consultation, and there will be when pharmacists are prescribing as well. And then there are inevitable problems with medicines because of the nature of them. And therefore, it's really important that we have a catch-up with patients and say, okay, every time a patient takes a drug, it is an experiment with an N of 1. Let's see what the results are, see how they're getting on with it, what their problems are from their perspective, because they're the people who will decide what to do, and then we can find solutions for them.